over 120 people already participating, and usually there's more than one person at a monitor, so that's a nice group of people who've come to listen to Dr. Paulo Enrique Silva Pelicioni. How did I do with that, Paulo?
No, you were great. Thank you.
I've been practicing to get that right. But we're just so delighted that you can join us at the webinar today. It is being recorded, so that it will be available on our YouTube channel in a few days, but also you've been willing to repeat the session at 7 o'clock tonight. And so we're really delighted. We've got two big groups of people listening. I know it's a little bit difficult with the webinar because you can't see your audience. It's a difficult one to present in, but we're really delighted that you're willing to give your time on this really tough topic. And your expertise, your research expertise, as I understand it, is this. You meet at the confluence of neurology and physiotherapy and mobility. That area is your area of expertise. And one of my overarching memories of my dad, who had Parkinson's, he was diagnosed when he was 70, and he progressed, deteriorated quite quickly. But I remember he would go for a walk and he would come back with these bleeding knees. It's a real memory of mine. He would go down on his knees, and of course his skin was really thin because he was in his 70s, and it would take us weeks, my mum and I, dressing it and putting ointment on to try and get, and sure enough we'd just get them healed and he would fall again. And it's one of the things that we as Parkies have to endure. I've had 2 tumbles myself, and whether it was caused by the Parkinson's or just being clumsy, who knows, but it really does knock you about when you fall down in a car park, and people see you falling, and there's embarrassment and injury and all those things. So not an easy topic, but a really, really important topic, and we're delighted that you're willing to give up your time to speak with us and to explain what we can do and how we can keep ourselves safe. So over to you. We'll, just for the listeners, Paulo will speak for about 35-40 minutes, and then we'll have some Q&A time at the end of that. Thank you, Paulo.
Kia ora, Andrew. Thank you so much for your introduction. For everyone else, tēnā koutou katoa. Ko kiriri patasha te iwi no Cidade São Jorge, Santo André, Parahiri, ahau, ko Silva Pelicioni tōku whānau, ko Mariusa Hawa, ko Saulo o Kumatua, ko Paulo Henrique tōku ingoa. So as Andrew introduced me brilliantly, I have a very long name, Paulo Henrique Silva Pelicioni. I'm originally from Brazil. I worked with the University of Otago down in Dunedin, and I'm currently living in Sydney in Australia as well. So since my undergraduate studies as a physiotherapy student, I've been interested in this topic, mainly on Parkinson's disease, and I've been researching on Parkinson's for 12 years, and I had quite a few experiences, mostly around mobility and how movement works on people with Parkinson's disease. And I'll be sharing some of academic, but also some of my views with you today. So I prepared some slides because that make things way easier. And before I go on to my slides, no reira tēnā koutou, tēnā tātou katoa. Okay, I will share these slides with you. Can you see my slides, Andrew?
Yeah? Yes, we can see that. Yeah. Great, thank you. Yeah.
Okay, and I just want to recap what Andrew said. It's not an easy topic to talk about. When you think about falls, usually it's something hard to digest because it is, people get hurt, serious things can happen because of falling over. But we need to understand falls in order to know what to do. So I will be talking about some numbers, some unpleasant things that happen because we need to be aware of it. And one of the ways how we can progress and how we can take care of ourselves is being aware of what falls is. So basically, falls happen in like from toddlers when I start learning to walking to older adults, and usually research is mostly done on older people. This is why I'm bringing some numbers see now, and also because Parkinson's mostly affect people aged over 60s, but I know also that there are some early cases of Parkinson's as well. So thinking about the ones of over 65 years old, per year up to 30% of them will have one fall, and over 50% of people over 8 years old will have one fall episode per year. And approximately 39% of those ones aged 65 years or older will have at least 2 falls per year. At least this is some information that we have from previous studies that followed up people during time and just checking if they had falls or not. For Parkinson's, what happens is at least the information varies from 45 to 68% that at least uh, from 45 to 68% of those living with Parkinson's will have one fall per year. And the ones having 2 or more falls per year vary from 50 to 86%. So we can see that how it is important, because unfortunately fall is highly present in the life of the ones living with Parkinson's. So, and it's just not impactful on the ones living with Parkinson's, their funnel, but also it has an economic cost associated to it. So falls are responsible for 14% of the hospital admissions and 4% of all hospital admissions. The 14% I mentioned is related to injuries, while 4% of all the hospitals admissions are related to falls. And it costs per year over 350 million New Zealand dollars. But I really think that these costs might be underestimated. Falls represent over 60% of direct costs of all, as we call, unintentional injuries, when we don't mean that these injuries were supposed to happen. And hospital counts account for over 65% of total costs of falls. So we can see that falls also bring a massive burden in finance overall. This topic became serious that even the World Health Organization started looking into it. So last year they have written down a document online. I'm happy to share with Andrew these links as well about some key facts about falls and people falling over, and some of the numbers that are out there worldwide as well. So they are looking into this in a way that, okay, what can we do to prevent falls overall? Okay, and just to make it clear, falls, it has an interesting definition. So we can define falls as an unexpected events which resulted in the participant or in the person coming to the ground floor or other lower levels. So that's how we usually define what falls mean. And falls can cause all sorts of injuries, and unfortunately some types of fractures, very common ones, fractures on the wrist when the person tries to hold themselves to falling and then ends up having injuries on the wrist. Hospitalization, of course, if that is an injury that causes more damage. And we know that once you are in the hospital, you have an exposed injury. Sometimes it can come with some complications. One thing that many people don't talk about, but which is also very serious, it's about the psychological consequence of falling. So people who fall, they tend to fear falling over again, and consequently, that reduce the quality of life of these people. They tend to not do much activities and be very fearful of falling. Falls can also cause some disabilities, and consequently, some people, they are so disabled that they might need to go to a residential care. And unfortunately, 1% of these falls can cause death, either directly or indirectly. When I say indirectly, we know that people can go to hospital, but they can develop some complications, and that's why it happens. And again, it's not an easy topic to talk about, but we need to be aware of the seriousness of falls. And when I talk about falls and when I think about falls, I think about 5 different questions, which are extremely important for us to understand. So what are the causes of falls? We need to know like what is causing people to fall. How a fall episode happened? Who are the people that are considered fallers? Do they look the same? Do they share the same characteristics in that case? And when does a fall episode happen? And where does a fall episode happen? So I will be talking about these 5 questions to you today. Once again, the World Health Organization is really looking into fall. So in one of their manuscripts online, they written down this risk factor model for falls in older age. And they linked to environmental risk factors, which I'll be talking to you today, behavioral risk factors as well, some socioeconomic risk factors that I'm not going too deeply, but we know that with social gapping, those ones with lack of social interaction, community resources, people from low income and educational levels, they are more likely to fall. And of course, there are some biological risk factors associated, such as age and some chronic illnesses. In our case, we will be talking about Parkinson's today. And the falls, I'll just go a little bit deeper now on Parkinson's in this discussion as well. So what are the causes of falls? Falls is what we call, it's multifactorial. People don't fall just because of one reason. They might fall because of many different reasons, and sometimes it comes from a cascade event. So someone has lower muscle strength and then stop walking, and then their walking gets a little bit wobbly, and then stop exercising, get overall weak and get depressed, and then start falling, and then unfortunately that could go downhill. But when we talk about what are the causes of falls, there are causes that we call intrinsic, but we call also biological causes of falls. In this context that I'm talking today, aging is also associated, not just getting old by itself, but there are some pathologies associated with aging, some rheumatological issues, for example, arthritis, some changes in the posture, changes with nutrition, and other factors that can make people more likely to fall. And in your context here, Parkinson's also is a biological cause for falls. Some symptoms related to Parkinson's can increase the likelihood of falls, but some biological issues that people might have been experiencing can be aggravated due to Parkinson's as well. And there are some what we call extrinsic causes or external causes for falling that I'll be talking to you in a bit as well. So when we talk about intrinsics or biological cause of falls, we can think about 5 different items, starting from cognitive impairment. So people who show cognitive impairment, like poor attention, some deficient memory, not completely fully understanding things well, they can be more likely to fall for not paying attention on the environment, and also for some damage that is happening in people's brain. Some psychological issues can also cause people to be more likely to fall. I mentioned before fear of falling. So when a person is fearful of falling, this one might feel just like more concerned to perform certain tasks, and then will stop performing certain activities, and then will be weaker and more likely to fall. Depression, anxiety, they are also linked to reduced mobility and falls as well. Some vestibular issues such as dizziness can make people more likely to fall. Vascular issues such as orthostatic hypotension that some of you might have experienced in the past, but also heard of it. Basically, when someone's getting up from a chair or just getting up from a lower level to a higher level, sometimes have that blackout and end up falling. And of course, there are some of the physiological impairments, the physical functionality that if it's not well, can increase the likelihood of falling. For example, people showing reduced muscle strength, slower movements, a poor balance, these factors can increase the likelihood of falling. Parkinson's wise, there are some symptoms that can increase the chance of falling. So the actual rigidity, like when people, there is stiffness around their necks, around their torso, so that can make a little bit trickier to turn around, for example, or just can alter and change the posture, which can increase the chance of falling. Dyskinesias, which are those involuntary movements around the extremity. I'm currently doing a study to understand the role of dyskinesia on falling as well, but people that are more likely to present some balance issues and consequently falling over. People who present freezing of gait, when the feet get stuck on the floor and then when they try to turn around, the body doesn't follow the command from the brain, and then the person falls over. High doses of levodopa. So there are a few studies showing that, of course, the neurologist prescribes what has to prescribe, but high dose of levodopa is linked to falling over, poor postural response when the person doesn't respond well to any perturbation from the surroundings, which is associated with Parkinson's. Some postural issues as well, like an inclined posture can increase the chance of falling. Balance instability, walking difficulty are associated with falling as well. Difficult with transferring, for example, transferring from a chair to another, or getting up from a chair and start walking. So if that is deficient, can increase the chance of falling. And one thing that not many people talk about, but it's highly linked with falls, is presenting urinary incontinence. So just for some things that happen in people's brain, but also when the person feels like, okay, I really need to go to the loo right now, and then the person might brush over and then might be so focused on that task that don't pay attention what is around, and then might fall over. I mentioned before the extrinsic cause of fall. So for example, it's everything that it's around us that might make us more likely to fall. Here, for example, we can see this pavement that it's all broken with some holes on the ground, very uneven. So that could really make us to trip over and fall down. On a slippery surface can really increase the chance of falling. So for example, or an icy, like when we have those black ices, you are walking, you are being careful, but still you might slip your foot, and then your whole body will just go to the ground. Crowded places, can induce to some anxiety, but or even like hitting one person or another, or this can cause some freezing, can trigger some freezing, and those ones presenting freezing of gait as well. Crowded room, crowded place like this, as we can see in this picture, in this room, there is not much space to move. So maybe tripping over on one furniture or just getting the feet stuck on the carpet can cause people to fall. We love pets, we adore pets. My cat just came to my room to say hi. He will jump on the computer very soon, as you will see. But they can be a little bit tricky, mainly dogs when they just run around past you. So this could cause us to not realize, oh, okay, there is something going on with my balance, and then we suddenly end up falling. And narrow pathways as well can cause people to, the ones who experience freezing, they can have that experience and then might fall over. But for general population as well, that can somehow challenge people's balance. And how does a fall happen? I will repeat a little bit what I said before, but there are three ways that we kind of define falls to better understand how falls happen and what we can do. There are what we call unexplained falls, and someone falls and you ask like, how did you fall? That person says, I don't know, which can be caused by syncope or pre-syncope. So the person was just a little bit lightheaded, had a little bit of blackout, and had a fall over. There are types of falls that we call balance-related falls. Those falls caused from trips and slips or sudden loss of balance. For example, you're reaching something out from the pantry, and then, or you went over too much and you end up just like not catching your balance and they end up falling. And one type of fall that is very specific, it's the fog, as we call for freezing of gait related falls. So these ones are the ones that, of course, are triggered by freezing of gait, mainly when people start walking, when they turn around, or when they are walking through a narrow pathway. And who are the fallers? I know that it's very hard to label people, but there are some characteristics that make people more likely to fall. So as I mentioned before, cognitive issues can increase the risk of falling. So those ones who have non-cognitive dysfunction, as we call, they are more likely to fall. Those ones living in residential aged care facilities, mainly the ones who have lack of social interaction, those ones are more likely to fall. People with Parkinson's, with postural instability and walking difficulty, of course, because of the characteristics of these symptoms, these people who have poor balance or their walk is more deficient, they of course can be more likely to fall for those reasons. The ones that we call freezers, the ones who present freezing of gait, and the ones who had at least 2 or more falls in a previous year, and that means that that person had experienced few falls before, and if these falls are not fixed, they are more likely to keep falling in the future. And when does a fall episode happen? So sometimes it's very hard to predict, but we were able from previous study to identify situations that can increase the risk of falling. So when the medication is fluctuating, so anytime that I see people with Parkinson's, I always ask about the medication, and some people say, oh, you know, the medication is wearing off 1 hour before I take my next dose. So go and speak to your neurologist or to your GP or to your geriatrician for that, because if you're not operating on a full-on mode, your body might require some of that dopamine that comes from the medication, but you don't have it, and when you need to respond to a challenge in the environment, for example, you might fall over because you are not on full operation mode. Early morning and late night are periods when people are more likely to fall as well, for all sorts of reasons, because of the vision as well when it's dark, but also because the medication might not be working very well during that period. Type of activity that you are performing might increase your risk of falling, such as, for example, try to reach out for something that it's way over your limits of stability, which means like way over to where you could actually reach without causing too much balance issues. Dual tasking, for example, walking and talking, walking and doing checking on your mobile, so that can cause distraction and can make people more likely to fall. And also, as I mentioned before, freezing of when people freeze, they are more likely to have a fall. And where does a fall episode happen? At home, uh, for all sorts of reasons, but falls at home are usually associated with frailty. People who are more frail, they end up not leaving home much, and then they stop doing what we call incidental activity, and they are more at home. They lack of some social connection, physical activity, and then they become more likely to fall. And those ones who have postural instability and gait difficulty, as I mentioned before, they are more likely to fall at home. And away from home, falls are also common, but they are more common for either for the ones who are exercising, doing some exercising, and then they, for example, running, or just, doing a power walk outside, then might trip over, or the environment is new for them. And as I mentioned below, unknown environment can increase the chance of falling as well, just because you don't know what to expect. So pavement that has a different texture, or you might not see a curb in front of you, or might differentiate a curb from the pavement, and that can cause people to fall as well. Okay, I spoke a lot about falls, but what can we do? Like, what are the treatment and therapeutics for assisting us to fall, to be less likely to fall? So again, I have 5 questions here for what could be the optimal treatment or therapeutic to help us to be less likely to fall. So I will talk about what's the best therapeutic, how to avoid falling, when should we look for help, where should we look for help or for treatment, and who should we look for treatment. So best therapeutics, levodopa through your medications, it's being considered as gold standard to treat some symptoms. Levodopa is not a one size fits all for walking, balance, and falls. So as I mentioned before, if people take too much levodopa, they can be more likely to experience a fall episode. Also associated with dyskinesia, that it's associated with high dose of medication intake. But overall, levodopa, of course, helps with symptoms. People stop shaking, they are less rigid, they are like faster, they don't show that slower pattern. So I'm not against it. I'm just saying that, of course, for any drug, they can also have side effects. Deep brain stimulation, of course, we know that helps with some Parkinson's symptoms as well. And I know that some neurologists have been prescribing cholinesterase inhibitor, which is associated to assist with some cognitive impairment as well. But when this drug is taken, there is some kind of links with the brain that also help. Apparently, there are some studies still going on that apparently it helps with mobility as well. But unfortunately, we have not found the best therapeutic when we talk about medication or surgery yet. It's still being explored, but these are some options that your neurologist could talk to you about. When we think about physical activity and exercise, there are some ideas about what could be the best. So when we think about exercise, um, isolated training, like doing one type of exercise, for example, or I go to the gym and I do weights, they seem not to reduce falls because it only works on one physical component instead of many different ones. So we have muscle strength, balance, as we call reaction time, how to react fast. We have mobility, we have flexibility. So if you work only one component, that might not be sufficient. Some studies showed that supervised challenging balance exercises, either in group or individually, they are more likely to reduce falls. So those exercises that really push you over, for example, during my PhD studies, we basically brought people to the lab and we made them to fall over. Of course, they haven't fallen on the ground because they were hanging on a safety harness, but we were just tripping and slipping people over using some paradigm that we had in the laboratory. And people were doing that like for over 1 hour. And at the end of the 3-month intervention, or 3-month exercise training, those people, they were falling less from slips and trips, showing that this type of challenging balance exercise, they can work. There is a very limited evidence that supervised home-based exercise, like using Zoom exercise, they reduce falls. They are very helpful for other to help with other physical functions, but not to reduce falls. And we need to think about when talking about physical activity and exercise to provide large dose and intensity. So go as much as you can, do as more intense as you can. It seems to be the case to help people to stop falling over, or at least to not fall more than they currently are. I would just go through this very quickly. There are some scientific evidence through some studies that show what had been working for older people, not specifically for Parkinson's, but I think it's worth it to mention. So I will use here as an example, gold bar evidence scale. So my previous supervisor, he shared with me, his name is Stephen Lord from Australia. And when you see in the written text that will come up in the next screen, 1 bar, it means that there was one big study done with that modality of therapeutics, okay? When you see 2 gold bars, there are some good evidence with at least 2 very large studies about that type of therapeutics. And when you see 3 gold bars, it means that there have been lots of study done about that type of therapeutic, showing that it's a good evidence to reduce falls. These, of course, studies took into account assessing balance and walking, if these therapeutics were good to improve balance and walking. And of course, they look into class attendance as well. Of course, we can't just suggest to do something if it's not enjoyable. If people are not attending, it means that might not be working for some reason. And also these studies, they looked into adverse impact and adverse event, if people were falling over, if people hurt themselves, or if some issue had happened. So basically, pharmacist-led education and GP medication review has some evidence to reduce risk of falling, but just in one large study. Podiatry intervention in people with foot pain, apparently that helps to reduce falling as well, because we know that foot pain can be impactful and be linked with falls. Withdrawal of psychoactive medications, of course, only following medical's advice to do that not by yourself. And multi-component and multifactorial interventions in people who are at high risk of falling, it seems to work. And what does multi-component and multifactorial means? Exercise with different modes of exercise. Strength, balance, walking, stretching, cardio, all of them together, it seems to be a good option. High balance exercise in group or at home, that seems to be for falls prevention in the community overall, the best and the best kind of prescription therapeutic to reduce falls, such as functional balance exercise, the Otago falls program that it's highly well known in New Zealand context, Tai Chi, it seems to be helpful. Some step training were equally good to reduce falls, home safety modification as well, and first eye cataract surgery seems to be effective, at least in one study, and the restriction of multifocal glasses and outdoor activities seems to help as well. When we think about discharging hospital for the ones who go to hospital for a few reasons, intensive exercise before leaving hospital seems to work as well. And in residential care, those multi-component and multifactorial interventions, as I mentioned, seem to work. Vitamin D supplementation, it seems to work as well, and it's highly recommended. Of course, excluding mega doses when you take like a bunch of drugs at once, that seems to provide an opposite effect. And medication review and physio exercise seems to be helpful as well. And what about Parkinson's overall, Paulo? So there are some recommendations that they were done from these folks in the UK. What they found out for Parkinson's from what's out there in the scientific community is that planning a multidimensional intervention, factorial, as I mentioned before, comprising balance exercise, strength exercise, exercise for your cognition, for your attention, your memory, and modifying the environment of your house, they seem to be more effective than just isolated exercises, as I mentioned before. For example, only balance exercise or only strength exercise or only walking exercise. Change your environment, it's also something that we really need to look into. For example, I know people love carpet, I'm the one of them, but these type of carpets, because they're loose on the ground, you might just sleep on them, or sometimes their edge is just like, you know, a little bit tilted up, you might just trip over and, you know, fall over. Something that help, for example, lifting the seat of the toilet, or having the bars to hold on, that assist people to be less likely to fall. Change the shower as well. For example, putting the bar on those walls that there aren't any, having some of those rubber mats on the shower that help to be less likely to slip and fall over. And in this house, for example, it looks tidy, but that carpet could be dangerous if it's not flattened on the ground in case of tripping over, or it depends on the type of the flooring as well. If it's too slippery, that also can be dangerous. To avoid falling, some of the advice that we give, it's when you notice that there is something with your body, like as we call intrinsic, like from inside going on, look for medical help. For example, some dizziness, orthostatic hypotension, if they are treated, you will be less likely to fall over from these reasons. If you know any existing cause external cause that is making you likely to fall or to lose your balance, try to eliminate or reduce that. For example, you might have that um, little carpet in your house, but you tripped over 5 times, you never have fallen down. But just, be careful, maybe get another carpet to try to get rid of that, to try to do something to get that carpet to not be that slippery or causing you to trip over. And know and recognize your limitations as well. So if you feel that your drug is not working very well and you might be more wobbly, maybe is it time to let's take a break here, 30 minutes, let's see how I do, or let's take the medication drug before, a little bit before, of course, if the doctor says it's fine, to see if that helps. But even I'm talking about exercise, physical exercise that are intense and everything, but you need to recognize your limitations as well. We don't need just to go over the top, but just recognize, oh, this is what I can do, and I will do the best as I can. When I should look for treatment, ASAP, as soon as possible. For when you are at early stages of Parkinson's, if you look for physical activity or any drug treatment, it facilitates any motor learning. So you become more likely to get more benefits from those therapeutics. But even if you are at mild to moderate stages of Parkinson's, these motor learning and also progression on physical activities, they are still possible. So I highly encourage you to go and look for that. It's never late to look for the best treatment that you can have. And keep your routine as much as you can, do as much as you can, of course, safely, and just be mindful. Try to be as much more independent as you can. Look for specialized help, not miracles that some people might be selling out there. And if you enjoy a new training, please do not stop doing your other activities. For example, oh, I'm now going to the gym, I don't need to go and walk to the groceries. If you can, you are not feeling too tired, keep walking to the groceries, because that will be helpful for your body. And look for people who understand you. We've been finding more and more and more evidences. I'm a physiotherapist, but evidences that working in a multidisciplinary group, it's the best option. So of course, that's not a message more for you living with Parkinson's, but more for health systems as well, and for health colleagues, that we need to work as a team to be able to facilitate the best treatment for you. And I have just a few take-home messages just to wrap this up. Keep active your body, your mind, socially, as much as you can. Look for help and support when you need. I know that it is that stigma. Some people, they just don't want to show that they have Parkinson's. And I actually can't understand that, but I can imagine how that could be difficult. But look for help and support. Maybe first reaching out for the ones that you know, or for someone that it's related to you, someone in your funnel, and then try to be open for help and support, because this would really help you out along the way with your journey with Parkinson's. If you know any extrinsic risk of falling, try to mitigate them, and then you'll be less likely to fall. And it's never too late to look for care, to take care of yourself. So please do it. I really hope that you leave this talk and just think, okay, I had a couple of falls last year, but I haven't been doing much exercise. So I might start going for a walk around my neighborhood, or just talk to a physiotherapist or to an exercise physiologist to see what they can do for me. And one last thing, as a researcher, I know that some people feel like, oh, I don't like being a guinea pig, but we have our heart on the right place when we think about this. But if you know any study that is recruiting, part of for balance treatments and this and that, of course, read the pamphlets and everything and check it out. It might be good for you, but if it's not exactly good for you, it might help the community and for future studies for us to understand what would be the best for you. Sounds good. I'm very glad to be here, and this is my contact via email or via Twitter. And thank you, Andrew, for this invitation. I feel very humbled, and it's always a pleasure to share a little bit of my knowledge with everyone.
Kia ora, Paulo. Thank you so much. Boy, who would have thought there was so much to falling over? Really interesting to think of all the different aspects. So we've got a couple of questions if we can.
Of course.
One is, you know, the person who's asked this question has described it as when you walk, you feel like you're falling forward. People with Parkinson's feel like, you know, they're like running, almost like you get that funny little, like funny walking motion. So the question is there any footwear that is better than others for people who got that sort of gait?
Okay, it's a kind of stumbling, right? Is that footwear? It's a tricky question because I mean, one thing about footwear is about people's experience. There are some people that they find you need to find comfort first of all, something that it's comfort. But of course, I know some people who love using Crocs, those sandals. They are comfortable, but they're tricky. You can get your feet stuck, you can fall over. I think I study type of shoes that has some grip on the soles, of course, to not slide down, slip over. That's an option. Avoid to use, you know, some heels if you can, or some tongs or flip-flops. But for this type of walking that you just incline forward, currently, I'm not aware of any specific type of footwear for that. I can actually search, and if I have this information, I actually know some colleagues who work with footwear. They might have this answer, and then I can share with you, and perhaps you can share with the attendees via email. But that's an interesting question.
Yeah. So, you know, the time comes when maybe a walker or a walking stick is an option, and I think it often can be a source of conflict because the person with Parkinson's doesn't want to admit that they've got to that stage.
Yeah.
Their carer will be saying, "Hey, you need a walker." So, two questions: what sort of like are the signs that you should look for to say, "Well, I've progressed to the point where I need a walking assistance"? And is a walking stick effective and like the first stage to a walker, or should you just progress straight to a walker?
Yeah, those are great questions. And yes, I can understand that issue about, oh, I don't want to show that I'm frail, but you need just to wait on. I know that some people think sometimes, oh, a walker just limits me so much. But if you end up not using a walker or walking stick or any assistive device, you might be, if that's the case for certain people, okay, I'll just try to go back a little bit. If you are not falling over, if you are independent, mobile, and if you are doing well, there is no reason for such. I know that some people, they feel fear of falling. They never had a fall, but they feel fearful. You really need to wait in. I'm not saying yes, not saying no, because it's from the person, and of course it's your physiotherapist or your doctor will help you out with that choice. But you should wait in, like, okay, shall I rely on something, or shall I just keep going a little bit more independent? But if that's the case, that you are falling over and you are hurting yourself, or even if you're not falling over but you had so much, as we call, near falls, you caught yourself on the wall, you hold on to something, you look to find your balance somewhere, and that's the time that you could think about, okay, I might need an assistive device. And we know that the walker is more sturdy because it has 4 points of support on the ground. and that doesn't tilt, so that helps you to hold on your balance. But it's hard to move. It depends on what you are doing. For some people, just the walking stick might do, because they just need that little bit of touch on the ground to help them to catch themselves. So I really think you could give it a go to a shop, test a little bit, bring one home. I think you can rent those out and practice a little bit. And I would just share just something very shortly, is that there are some studies that they show if you just touch something very lightly, like I'm doing, touching my finger, that helps you with your balance. So that might be the case with a walking sticker. You just might be needing that incentive just to, okay, now I feel more confident, or now I feel less wobbly. So those could be the way. But if you are struggling with your balance, falling over, yes, please look for help from your physiotherapist, your GP, to end up using one. It's helpful.
Because presumably keeping mobile, I mean, you could look at your presentation and say, gee whiz, there's so much danger, I'm just going to stay at home and stay in my chair, but that would actually be worse, wouldn't it? It's better to be active and to use a walker or a walking stick to keep yourself going.
Exactly, because if you stop, you lose all the benefits from exercise, cardio, muscle strength, social connectedness, and all sorts of things. I'm a highly advocate for exercise. Regardless what you do, keep doing them. Keep yourself active. I know it's hard to say. It's easy to say, but it's hard sometimes to do. But keep doing it. Or if you haven't started, I highly encourage you, because you get so many benefits from it.
And one participant is reminding us that walkers are often funded or subsidized.
Okay.
To get them through your physiotherapist. You can get assistance you don't have to go off to a shop and buy one. You can actually get one supplied through the health system.
Oh,
so
wow.
That's a helpful tip from someone who's participating. So another person is asking us, a lot of research in New Zealand is neurological and scientific, but you gave the example of, where for your PhD studies, where you were suspending them and like doing really practical. So in New Zealand, how much research is around really the practical aspects of helping people with Parkinson's versus the more scientific neurological research?
Yeah, that's a good question. And I mean, I don't like criticizing what is being done, because I really think any type of research is important, but not in detriment what have been done for genetics, for brain studies, but maybe on top of that, researchers really should be funded for more research to be done on physical activity, physical mobility, because we know that it's not just the drug that helps, it's not just understanding the genetics of Parkinson's or what's going on in their brain, because we know that people living with Parkinson's, they will be living with Parkinson's. They need a better quality of care. And if we don't invest on the quality of care, we can find out what caused Parkinson's. Okay, but what about the ones living with Parkinson's? We need to care for them. And yes, and if there is anyone watching here, any funder, any foundation, please invest in these, or just open calls for physical activities, physical exercise, mobility programs for people with Parkinson's disease. That would be very helpful.
And then another question is, you mentioned the vitamin D having advantage, and someone's asking, can you give a little bit more detail around dosage and how much, or how do they find out more information?
Oh, lovely. I would love to, but it's out of my jurisdiction as a physiotherapist. But what I read and what I spoke to some colleagues is that there are different ways that you can take vitamin D. Either, for example, one big extra dose of vitamin D, and also you can break it down. Apparently, when you taking it down, for example, a pill here and there, that it's more helpful. That supplementation of vitamin D, it's more helpful, and that actually is associated with falls reduction instead of taking one big dose, because the big dose might have side effect that other drugs do have, and then might cause you some negative impact or side effect. If you are taking the dose, or if you're not taking vitamin D, go and speak to your GP or in your geriatrician, because they will certainly be able to help you out with that.
Right, right. And a pharmacist would possibly give some advice as well? The
Sorry?
pharmacist?
Yeah,
Pharmacist?
the pharmacist as well. Yes, as well.
So, Paulo, we're getting close to the end of our time. Can you just comment on carrying things? So, something as simple as a cup of coffee, but it might be the parcels, you bring in the groceries, or maybe your grandchild. So like, are there any tips, anything that you've got to be careful of? Is there any comment that you can make about how you hold something when you're carrying?
That's interesting. Part of my study, I actually do one of the tests that people have to carry a plastic cup, of course, empty on a top of plate, and they have to walk around with that. I know that with the shaking, for example, to bring a parcel, someone might shake and might be tricky, or carrying a cup of coffee. So for the shaking by itself, I mean, I would try to hold with 2 hands, or if you have a trolley at home, that would be make things easier, we would do that. But if the person doesn't have that, as we call postural tremor, when you are holding something, I would just be careful and watch your steps. Because when you carry something, you are doing something that we call, and I mentioned before, dual tasking. So you perform 2 tasks at once. So you are you are focusing on 2 tasks. Oh, I need to walk fine to not trip over, and I can't drop this baby on the ground. So just be careful, take, nice steps, be mindful of your surroundings, no need to rush, really think about what you are doing, think about your steps, and perform those steps nicely. And of course, know your limits. I know that, for example, you like bringing your coffee over, but if they are spilling, try to change your strategy using a wee trolley, or if you have any help, I'm sure that people would be pleased to bring you a coffee, and you do the best part, just enjoy the coffee.
And then maybe the last question for today, because we're just on time. You mentioned that it's possible to have too much levodopa.
Yeah.
So what are some of the signs that someone should look for to think, oh, I need to ask my neurologist about this? What does too much levodopa look like?
Yeah, so that's a great question. The drug treatment is really individual. So there are some people, for example, when they take into account, they calculate the levodopa from many different drugs that they take in a day. And let's say they take 1000 milligrams of levodopa in a day. For that person, that works fine. That's it. No side effects, nothing. But what I've seen in reading these research articles is that for early onset Parkinson's people, those ones who take, I think, more than 650 milligrams of levodopa, they start being more likely to have dyskinesia. So dyskinesia is a kind of side effect, those involuntary movements that sometimes people have on their hands, feet, and neck as well. It means that they're perhaps either taking too much levodopa in a day, or they've been taking levodopa for such a long time. So that's when the doctors start thinking, oh, okay, I think you could go through some deep brain stimulation if that is prescribed for certain people. I know that there are some contraindications, some indications, exclusions, and but if you notice that you are having some uncontrolled movements, talk to your doctor. Or if you notice that there is something unusual, because we, even without not knowing much about the drug, but we have sometimes that feeling that, oh, I think since I changed the dose of the drug, I'm feeling more sleepy, or I'm feeling that I have to go to the toilet more often. Report those things to your doctor, but most importantly, don't stop taking them. like by yourself, no, this drug doesn't work for me, I'll stop taking it. Because people benefit from the drug for sure. It's just if the dose is too much, and then that can be tricky. But once again, speak to your neurologist, and it's not a cake recipe. There is no too much, but if you see that you are taking too much drugs, not taking much benefit of it, and have too much side effects, that's certainly the time for you to be talking to your doctor.
It sure is a bit counterintuitive, because I've just been through that experience recently where family members had noticed that some of my involuntary hand movements had got more extreme, and so the logic says, "Oh, I need more levodopa."
Yeah.
In fact, I went to see my neurologist recently, and he said, "No, I think we've got to cut back the levodopa. I think it's the levodopa that's poison." So it's a bit counterintuitive, but you think the symptoms are getting worse, I need more.
Yeah.
It's quite an interesting one to get the balance.
Yes, that's interesting.
And one last question that just come in is that his partner likes to party, and so what's the your recommendations around drinking too much and Parkinson's?
Yeah, so there is a kind of link between the medication doesn't not working very well when people drink. I can't recommend anything, because first of all, I'm not a doctor nor a pharmacist, so I might just be shooting my foot. But I always think about me. I'm talking about Paulo, okay? I like to live my life, not to do silly things. I'm not jumping from an airplane without a parachute. But if that's something that brings you a joy, for example, oh, I like going to a pub on Friday, and my husband will be driving, and I'll have 2 half pints that night. Talk to your doctor, see what he thinks. I like to have 1 glass of wine on Sunday, with some pasta for dinner. Talk to your doctor, because I really think that if that's something that brings joy to your life, and if you like that party, and if it's possible according to the medication that you take, why not? But talk to your doctor, because I don't want to give an incentive to alcohol, to be drinking alcohol or anything. But if it's something that makes you happy, of course, as long as don't take many, because that's not good for anyone. But speak to your doctor, and I think that that's something great to do.
Thank you, Paulo. And just one of the people on the chat has just said, just want to express their thanks to you for this really engaging presentation that you've made. As I said at the beginning, I know it's really difficult talking at a blank screen and not being able to give any non-verbal cues back from your audience, but we've had over 130 people on the chat today. So thank you so much for your time and your expertise. We really, really do appreciate it. And I look forward to seeing you at 7 o'clock tonight. Anybody else who wants to rejoin, or the seminar has been recorded and it will be on the YouTube channel in the next few days. Everyone will get an email to tell them those details in the next few days. So thank you, Paulo. Enjoy the rest of your day. Thank you, everyone, for participating. Everyone who's been on the call, thank you so much. Kia ora.
Thank you.
And we'll talk again soon. Thank you so much.
I'm looking forward to talk to either you, of course, I know you'll be there, but other folks, if they are rejoining, and the new people this evening. I'm really looking forward to this as well.
Thank you, Paulo.
I'll see you all later. Bye-bye.
Stay safe out there. No falling.